Next up, we'll be asking health industry stakeholders what they're doing to help patients benefit from innovative healthcare resources, what's working well, and what public and private sector initiatives should we consider in the future. To find out, please welcome on stage Keith Reynolds, Vice President of Enterprise Health Plans at CVS Health, Crystal Fry, Vice President of Human Resources at Continental Realty Corporation, Dr. Joyce Nestrick, President of the American Association of Nurse Practitioners, and John Rother, President and CEO of the National Coalition on Healthcare. The Hills Healthcare reporter Rachel Rubine will be leading this conversation. Rachel, over to you.
Hi, good morning, everyone. Thanks for coming out today. Special thanks to our panelists as well. We have just 30 minutes, so I want to dive right in here. So no secret, healthcare can be very complex for those of us who live and breathe it every day, let alone the patient. So John, what should we be doing to help kind of the patient better understand healthcare and better be in control of their well-being and the costs associated with it?
Well, I think there are three critical things from a policy point of view right now. One is we need to help people stay healthy, so their investment in the Prevention Trust Fund is crucial. Population health is the ultimate answer to keep people out of hospitals and keep them healthy longer. Secondly, people who are increasingly experiencing chronic conditions, that's often the result of individual behavior. And education can help, but we know that education by itself isn't enough, that people need contact with other people to help them do better in terms of maintaining their own health. People with multiple chronic conditions account for a very large portion of our healthcare spending. And the third issue that people face increasingly today is affordability. If you can't afford to get the care, then you're going to get sicker and end up in the emergency room. So prevention, better self-care around chronic conditions, and affordability are the key things going forward.
Mm-hmm. And Joyce, John mentioned chronic conditions and prevention. Sort of from the nurse practitioner standpoint, how can you guys help with that?
So nurse practitioners partner with their patients in terms of preventing disease processes. It's part of what we've always done in terms of helping patients prevent diseases. And even on our website, we have tools for our providers to help them partner with their patients, which is important. So I think getting to know your patient, know their needs, and what you can do to help them prevent the disease is important. So for instance, I have a bad diabetic patient who eats at the local food bank and food pantry. So I actually went there to see what she was choosing in terms of her food choices and what she eats there in order to help her manage her diabetes better. Because if we don't understand where patients are coming from, we really can't help them in the prevention of their diseases.
Mm-hmm. And kind of looping in the employer perspective, Crystal, I mean, how do you think and what should employers be doing in terms of helping with employees' well-being?
So we have a very unique opportunity. 177 million or more Americans receive their health care through employer-sponsored plans. I practiced HR for 21 years and have always been involved in managing employer-sponsored plans for many years. And many of those people spend a lot of their time at work. So we really have a unique opportunity to educate and inform people about healthy choices that they can make about managing their own chronic diseases. I heard both congressmen mention how flexibility and prevention were so key to making a difference in patient outcomes. And I think we are uniquely positioned to help with that educational process, information, and really engaging people in their own health.
Mm-hmm. Telehealth was also mentioned. So Joyce, you mentioned you've worked with telehealth a little bit. Can you talk to us a little bit about that and any challenges or barriers to it?
Well, I think as both congressmen mentioned, there are barriers with telehealth considering is it that where the patient is or where you are. There's reimbursement issues for all providers related to telehealth, but telehealth can work very well. We have a lot of nurse practitioner innovators who have been using telehealth for various purposes. So myself, I have used it to help my coworker manage a clinic in rural Pennsylvania that doesn't have access to a provider. So she's also in Pennsylvania, and we manage these patients in this rural setting using telemedicine with the use of a registered nurse on site that helps us manipulate the equipment. And so we have had very good success with that. We also have nurse practitioner entrepreneurs that have worked with telemedicine, say with truck drivers across the road that can report their blood sugar, their blood pressure, and how much exercise, those sort of things that impact our national truck drivers, keeping them safe and keeping the roadway safe.
Mm-hmm. And in terms of nurse practitioners, there's some states where they have kind of full practice authority and some where it's more limited and restricted. So can you tell us a little bit about challenges associated with that and sort of what you would like kind of on the policy front on that?
So we have 22 states, including the district here, that are independent or autonomous practice states where nurse practitioners have no supervisory or collaborative language to practice with physicians. However, we have many states, mostly due to outdated regulatory language. Most of it was written before we existed, and so it really needs to be changed to allow patients to have full access to nurse practitioner care. And I think that's important at the state and federal level. We have some issues related to home health care. We, for instance, cannot order home health care for our patients unless they see a physician. So that is a cost and access issue for our patients. So I work in a rural area. It may cause one of my patients to travel a distance. I also work with underserved clients, so it would cost them an additional visit to see a physician, and then maybe they would get their home health care after all of that is said and done. And most likely during that process, they'll end up in the hospital or some higher cost place. So removing barriers for reimbursement for nurse practitioners and for our licensure is a huge issue for us because we want patients to be able to choose nurse practitioner as their primary care provider. And 89% of nurse practitioners still practice in primary care, and we see both Medicare and Medicaid patients.
Mm-hmm. And kind of turning to prescription drugs for a second, CVS Health, in terms of opioids, recently changed the prescribing maximum to 7 days and for acute pain specifically. So I'm curious a little bit if there are other efforts in the works that PBMs are doing or that you think should be done.
Specifically to opioids or in general?
Just opioids, and then also kind of in general widening that out.
Yeah, a week or two ago we made a bold announcement where we are limiting first fills to a 7-day supply of opioids. I think that's a big public policy statement and really public health win here. What we've realized is that the day supply on hand has gone up dramatically over the last 10 years. So if you look at the day supply of opioids on hand 10 years ago, it was approximately 11 days. In the last year, it's crept up to 14 or 15 days. The rate of addiction goes up as day supply increases. So by limiting that, that was a big move. We're also now enabling our pharmacists to counsel members effectively about how to use these opioids and then what to do with them once you're done with them. So if you have extra supply on hand, not to leave them in your medicine cabinet or not to throw them away, but to dispose of them safely. And to support that, we've had previously about 750 boxes, disposal boxes in law enforcement. that individuals could take their medications back to. While that was good, it didn't make it as convenient as we could. So we're now putting in 800 more boxes around our CVS pharmacies nationwide, mostly focused in our 24-hour stores. So that's one thing that we continue to work on to address the epidemic here. But then we're also really enabling our pharmacists to provide greater counseling and really play a key role in healthcare. You heard Congressman Barrett say prevention's key, and that other healthcare providers could do more to lower overall healthcare costs. And as a pharmacy benefit manager, we fit squarely in that area. Pharmacy benefits are probably one of the most widely used benefits in a health plan or an employer-sponsored plan. We are talking about individuals with chronic disease. 86% of our healthcare dollars go to managing chronic conditions. Many have comorbidities, and when you think about these individuals, they're managing 8 to 16 prescriptions a day. That's a lot of prescriptions. We have all that data as a pharmacy benefit manager, and we're able to actually design interventions to help these individuals manage their care. So diabetes is a great example. Making sure somebody has controlled A1C leads to improved overall healthcare outcomes. So making sure that they're adherent to their medication. They know how to take their medication, when during the day to take that medication. And then reinforcing that over time with counseling. And then referring to nurse practitioners to make sure that or their primary care physicians to make sure that their A1Cs are well managed, and linking them up with a healthcare coach as well. So there's a great opportunity for pharmacy benefit managers to really play a crucial role in lowering overall healthcare costs.
In terms of that, in the debate over prescription drug pricing, there's been a lot of talk about just transparency of pricing. So I'd love to get your thoughts on what PBMs could be doing on that.
I think PBMs have done a very good job in managing overall costs. What you've seen a move to is really managed formularies and making sure that individuals are taking the appropriate medications at the lowest possible cost. So driving to generic drugs when possible. When there's not a generic available, then making sure that we are acquiring the branded product at the lowest possible cost. So we have done a very good job as an industry to drive to that. If you look at clients that have a managed formulary versus those that don't, last year on a PMPM basis, a managed formulary client spent $89 per member per month, compared to clients that did not manage a formulary spent $113 per member per month. Those savings do go through to the member because they're accessing lower cost alternatives.
I think there's two problems, though. One is we still don't have information we need about rebates and just how those prices and those savings get translated through the system once the manufacturer sets a sales price. The other problem here is we may be able to save when people are receiving through their plan, but not when they're paying out of pocket in the deductible period. Then they're paying the full list price often. So that's a concern, and it stops people from getting the medications they need to stay healthy.
John, you bring up a very good point there. With the advent of high deductible health plans, we have seen this kind of a disconnect between the gross cost of a drug and the net cost of the drug. So 90 to 93% of rebate value gets passed through to employers or to health plans. Oftentimes that has gone into lowering overall premiums or reducing payroll deductions. But when you're in a high deductible health plan, that rebate may not make it to a member directly. It's indirect in the sense that they're paying a lower premium or a lower payroll deduction. But there are ways to enable rebates to make it to the end user, and that's applying that rebate dollar at the point of sale. So when that member goes in to get that prescription that has a rebate attached to it, they get the benefit of that. That will certainly help with affordability.
I also think that nurse practitioners and other providers working in the team-based model with pharmacists and other providers helps us to understand the cost of medication. And when we work with pharmacists and others in that team base, we are able to help lower the cost for the patients.
Mm-hmm. And Crystal, bringing it back to kind of the employers, are there any sort of initiatives kind of specifically in terms of helping with employees' well-being and also in sort of crafting the healthcare plans that employers choose to have their employees sign up on?
Yeah, absolutely. I think one of the things that employers can do is to offer non-traditional benefits that are becoming quite popular and utilized. And they are a great way for people to manage health and well-being. So some examples can be things like on-site yoga, meditation. You know, some of these less traditional forms of benefits that also do have a great health benefit and help people to really achieve a great life balance, work and life balance. So those are some of the things that we've been doing. One of the things that we've also done is we sort of recognize that, a third of our group really work in sedentary jobs. So they're sitting at a desk. And so we started a standing desk program where employees can engage in a 30-day challenge. It's a wellness challenge. A lot of the challenge is around how to use a standing desk properly and safely, and then just the benefits of it and that sort of thing. And they were able to have a standing desk, and it's been very well received. 50% of the employees who are eligible for it use standing desks now, so it just helps to get them up and moving. So we can do a lot of things like that that really improve well-being over time. And those kinds of lifestyle changes that were mentioned earlier, we can really help to educate and inform people about.
And John, I want to talk a little bit about value-based care and moving from value to volume. So what's kind of the state of that right now, and sort of where are the inherent challenges of moving to a value-based system?
Well, one inherent challenge is that we need to agree on what value is, how to measure it. It's being used for lots of different ideas. One idea is to pay for outcomes. So if a drug works and it reduces other costs, then you can pay a higher price than if it doesn't work, you really shouldn't pay for it at all. But another way to talk about this is we know that certain procedures, certain interventions have a much greater, more beneficial impact than others. And we should probably make that clear to people by varying how much we pay through coverage, how much we vary their outpatient, out-of-pocket costs. So that's a value-based benefit design. And I think we want to go one more thing to go back to is we know increasingly that the social determinants of health are actually much more important than medical care, but yet we don't pay for that. We don't value that. And so what good does it do to cut education or cut housing or cut nutrition in order to pay for Medicare? Medicaid, if what the result is that people arrive at the doctor's office or at the hospital in much worse shape. And that basically is what's happening today. So when we take a value perspective on healthcare, it really does change how we need to behave across the board, not just in one piece. And so it's a big, important idea, but we do need to agree on how to measure value.
And can you talk about paying for value a little bit in the prescription drug space, Keith?
Yeah, there's multiple ways that we can think about paying for value. And it's really aligning incentives with that of our clients oftentimes. So with the pharmaceutical manufacturers, we can actually look to enter into value-based contracts and paying for drugs that are proven to work in certain areas. And we're starting to see this in specialty, where specialty drugs may have a broad indication to treat multiple conditions, and then designing a formulary around the drug that treats that right condition and paying a certain amount, or having the manufacturer contract specifically to that condition, and then looking at another condition and selecting a competing drug that provides the most value to that patient. It may be at a lower cost, it may have better quality outcomes. So we're working on that right now. We've launched a few programs. And then we're also looking at how do we take risk with that of our clients. So largely in the pharmacy benefit management space, it's been fee for service. So I'm tasked with, in the organization, how can we look to align our incentives and go at risk for a pharmacy benefit management program so that we are standing behind our programs, our clinical programs, our utilization management, our formulary construct to drive overall lower cost to that of our client. So we're entering into that space. And Tom Scully mentioned that with Medicare just previously and how that worked. We're looking to adapt that in more of the commercial space now.
Mm-hmm. And earlier you had mentioned medication adherence. So is there anything that you guys are doing on that?
Yeah, there's a tremendous amount of work on medication adherence. We know if we can make sure individuals are using the right drug at the lowest possible price, and then providing appropriate counseling and messaging to them and engaging them, that we can lower overall healthcare cost. Pharmacy still represents one of the best values in healthcare, especially with the numerous generic drugs that are on the marketplace. Individuals left to their own devices will not stay adherent to the medication. So how can we support those individuals? With our model, we support it through face-to-face counseling at the retail pharmacy, also backed up with health coaching for members with diabetes to make sure that they understand not only how to take their medications, but what other lifestyle implications could be driving adverse results for them. And then incorporating all that information back into the really the medical home. So how can we get that information to the primary care physician that's treating them or that nurse practitioner?
Joyce, what do you think works best in medication adherence and who's kind of the right person that patients tend to kind of listen to in terms of adhering to their medication?
I think it's a combination of a team approach, and nurse practitioners have always been interested in quality care and adherence. So we spend a lot of time talking with our patients about the medications, and studies show that the patients like that we spend more time with them. And so we spend time talking about the medication, the reasons they need to stay on the medication, and perhaps why they're not taking it. So a lot of times we find that cost may be an issue. So we find that a patient is cutting the medication in half because they can't afford it, or they're taking it every other day. And so those are things that you find out in that one-on-one patient conversation. And sometimes it's also our pharmacy colleagues that let us know, that this particular patient has not picked up their prescription for a month, or they're only picking it up every other month. So we know as we work together that the patient's not adhering to the medication the way we want them to. Sometimes side effects are an issue that needs to be discussed one-on-one. So you find out it's some sort of little side effect with the patient that you need to work with them a little bit more closely. So if it's impacting their work environment, if they have to use the restroom more often, they may not want to adhere to that medication. So you need to find out the underlying causes of why they're not adherent.
And John, I'd love to get your thoughts on that. And real quick, we're going to turn to audience Q&A in just a minute. So if you have any questions, be thinking of those. And John, did you have thoughts on medication adherence and kind of empowering the patient?
Well, adherence is a much bigger problem than most people will acknowledge. I think there was one study that shows after about 6 months, about half of patients with chronic diseases are no longer taking the appropriate medication. So there's a variety of reasons for that. Information and education alone does not seem to work. So I do think the human element is critical here. And we need to make sure, too, that we can track outcomes. We don't really have a system for knowing what the impact is over time. And that's going to be more and more important as people have multiple chronic conditions or taking all different kinds of medication. So that this is a big issue, and it's one that really requires us to think more broadly, I think, about how do we track and maintain people through episodes and as well as chronic therapies.
All right, we'll turn to audience Q&A. Anybody have a question? Over there.
Hi, thank you everyone for your great remarks. My name is Nicole Braccio from the National Patient Advocate Foundation, and we are actually huge proponents of shared decision-making between the provider and the patient. I think that's something everyone here has alluded to, the fact that that human contact is really important for medication adherence. So Joyce, I'd love to know your thoughts about if in your practice, do you typically have that initial conversation before treatment selection to determine, based on the patient and family preferences, what are they most likely to stay adherent to? And that might be kind of the best way, to have them continue that therapy and ultimately, benefit the most from it.
So I think it's important to know the culture of your patients. So for instance, I work in rural Appalachia, and there's many patients that I would like to start on an injectable to treat their diabetes, but I know that in that culture, that has a stigma attached to it. So oftentimes I might have to start at a different medication and then do a lot of explaining over and over if they have to move to that medication because I know they're not going to be adherent. I've also had patients who are perhaps homeless or unable to take medications daily, that we've been able to get a weekly or a monthly medication for them, worked with the pharmaceutical companies to say, this patient, I could get them stable if I can get them on a weekly medicine, that I know that they could come in and we can administer the medication for them. And that's worked very well, but it does take a team effort to get that medication covered, and sometimes working with the employer to give them the time off to come in weekly. So there's a lot of work when you just find out about the patient and their environment and their choices. And I think we see a decrease in visits when we allow patients and to have choices, and we see an increase in adherence that decreases maybe up to 12% of hospital readmissions when we start to look at including the patient.
I would just add there's a great opportunity to help support the providers in the community with actionable information. And we're working on an initiative that is really point of prescribing type initiative to move data further upstream. So when the physician or the nurse practitioner is prescribing a medication, they have access to the information, whether the drug requires a prior authorization, there's a lower cost generic available, the product is a formulary and will be at a lower cost to a non-formulary product. So then that physician or nurse practitioner is making that decision on what to prescribe. The member then has a better experience, or in this case, the patient, when they go and get their prescription, and they get the prescription exactly as their physician wrote it and were counseled on. So there's a great opportunity there. In the fourth quarter of this year, we'll be launching a pilot to work with physicians in this regard to make sure that there's more information at the time of prescribing, to your point around the team approach.
And if I may weigh in on the employer's perspective, the sort of thing that we can do in designing wellness programs is to encourage that regular relationship. So one of the things we do is we provide an incentive for getting your annual physical. We do not get results. We just want to help establish that relationship with the care provider, that we know our team members are establishing an ongoing relationship with the care provider, and we do provide additional paid leave for them to be able to go for that appointment annually, because we think it's important that they have the established relationship for the reasons you're saying.
And unfortunately, we're out of time, but thanks everyone for the great conversation.
Thank you, Rachel, and to our panelists. That brings us to the end of our program. On behalf of the Hill and our sponsor, the Coalition for Affordable Prescription Drugs, I'd like to thank all of you for joining. If you missed any portion of the program, the live stream video will be available on thehill.com later today. And as a reminder, we would love your feedback, so fill out those surveys. Have a great rest of your day. Thanks.